Welcome to the Fresh RN podcast. In this podcast, we will be discussing various nursing scenarios, personal experiences, policies, and procedures. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing and respective facilities' policies, procedures, and protocols to guide your practice. Thanks, nurses. Stay fresh. And we love trains.
I needed like nausea medicine or something.
Did you
crazy.
need 4 milligrams of Zofran? Okay, I think my hypertensive crisis has resolved.
Toot toot.
To communicate.
Yeah.
Boop-a-dub-a-dub.
And you'll get grumpy doctors who don't want to be called back.
How'd that go?
That's actually a little bit of a pet peeve of mine.
Welcome to the podcast. I am Katie Kleber.
I'm Elizabeth Mills, and this is the Fresh RN podcast.
What? And on this Fresh RN podcast, we're going to talk about working with advanced practitioners. And that can mean physicians, residents, medical students. Well, maybe not medical students, but nurse practitioners, physician's assistants. Did I get them all? Is that all of them?
Yeah, CRNAs, things like that.
Yeah.
I mean, people basically...
Who's giving the orders?
Yeah. Communicating with them so that you can get what your patient needs.
So an important aspect of this is kind of understanding what their schedules are.
Yeah, and you have you've got your patient has a medical team looking out after them. You have the attending, which is usually, the name of the doctor that you see first on their chart.
The main doctor that is they're
running the show.
They're running the show. Like they see the patient, and if they think it's appropriate, they'll consult a doctor from another service line.
Right.
But that consulting doctor can come take a look at the patient, but they're not the attending, so they may not put in some of the orders, or they may, they're not, I feel like...
They're working with the physician, but they're consulting. So if, let's say, your patient has come in with a stroke and they have a new diagnosis of atrial fibrillation, a lot of times cardiology will be consulted. Well, you know what? That patient needs to go on a blood thinner. The cardiologist thinks that patient needs to go on a blood thinner. Well, you know what? Maybe they should talk to the attending, if that's a neurologist or whatever. Or, let's talk and make sure they're okay with that plan. So that happens a lot of times.
Yeah, because when I went into nursing, I just thought, there's like a doctor and that's it. But there's so much more.
There's so many. And it's important for you as a nurse to know who's seeing your patient. And that's actually something that should be reported when you're doing shift report.
Mm-hmm. And if not, you should easily be able to tell from the chart who's the attending physician and who are all the consulting physicians.
Right.
So let's say let's go with that scenario she was talking about. Your patient was admitted with a stroke. Let's say the neurologist is the attending. They've consulted the cardiologist, okay? So let's say that's kind of our scenario. If they want to do if the patient's in atrial fibrillation and we want to do blood thinners, that cardiologist most likely is going to either write in their note, hey, I think we need to do a blood thinner, and it's up to that neurologist to decide, yes, we want to do that or not, or yes, it's safe or not, and then defer back to them to figure out the dosage, or they'll do it themselves.
Right.
So, but let's say we've got that neurologist that's the attending. So let's say it's Dr. Smith, and Dr. Smith is there from 8 to 5, Monday through Friday. But they do something where they take call. So there's multiple doctors that are in a service line, that are colleagues of that neurologist. So maybe there's Dr. Smith is seeing your patient, but there's Dr. Jones and Dr. Thomas and Dr. Meyer, and you have those are all the colleagues. We know a Dr. Meyer. We're chuckling because he's not a neurologist. He's actually a neurointensivist.
Yeah,
but anyways, so you have additional ones so that they take turns covering overnight for each other. So that means if you have your patient is Mr. Smith, Dr. Smith, and you have a need at 7 p.m., you have to call the on-call doctor. So let's talk a little bit about that.
Yeah. All right, so you've got an issue and it's nighttime, and you're calling the you're needing to page the doctor on call. You need to assume that doctor does not is not familiar with your patient. So you need to have all the information ready to communicate to that physician so that you can describe that patient, describe what's going on, and get what you need. I, as a new nurse, the first time I ever paged a doctor on call,
how'd that go?
of course, I got tongue-tied. I literally forgot what was going on with my patient.
I think I did that too.
I needed like nausea medicine or something.
Did you
crazy.
need 4 milligrams of Zofran?
And I literally was like, "Hey, I'm taking care of so and so, and they had a procedure." I think I literally said that, and they were like, "Okay, what did they have?" Anyway, so something that you might want to do is write it down. Write down what you need to ask. There's this, is it acronym?
SBAR. Yes.
Acronym called SBAR, SBAR, that is good to use in order to deliver the message. S stands for situation. B stands for background. A stands for assessment, and R stands for recommendations. So they teach it a lot. I know they talk about it in our, I know we have like monthly, or not monthly, but annual skills.
Yeah.
CBLs.
Use SBAR format
online,
to communicate.
Yeah.
But that sounds so robotic. Like, how does that really look? Like, okay, so wait, in my mind I'm thinking, okay, so let's say you had to call Dr. Smith. And actually, what if it was Dr. Smith's turn that was actually on? And the way you call and talk to him is going to be different than one of his colleagues. So, because Dr. Smith, and Dr. Smith knows this patient. So, hey, I'm just calling you about Sarah Johnson. Remember, she's the patient, blah, blah, blah. Oh, yeah, what's going on with Sarah? Like that physician that admitted the patient, that is the attending, is going to be theoretically should be familiar with that patient. So you're not going to need to give near as much background to Dr. Smith as, let's say, if Dr. Meyer is on for that night. When you call and Dr. Meyer responds, you say, hey, Dr. Meyer, I'm calling you about Dr. Smith's patient, Sarah Johnson. She was admitted with a stroke. She's also got a little AFib going on, and we're waiting until we can start a blood thinner. My question is blank. Like, you want to give a little bit of background to the situation. Now, you don't want to like go through report like you got from the nurse. You want like super quick to let them kind of understand the situation and the background. Because you calling the on-call physician, you want to have this kind of assumption they don't know that much about the patient.
No, yeah, you need to assume.
And if you're not sure, you can say, hey, because I've worked with some service lines where there's only 2 or 3 physicians, and they're actually pretty familiar with each other's patients. So if I'm not sure, I'll just say, hey, I'm calling about Dr. Smith's patient, Sarah Johnson. Are you familiar with her at all? And they'll say, no. Most of the time, I'll say, no, I don't know anything about her. What's going on?
Yeah, right.
So approaching that differently is kind of important, I think.
Right. And I always say, are you familiar with this person most of the time? So what you basically need to say is kind of what we just went through. You're going to mention the patient's name. I always like to say where they are. Like,
yes, because they don't always know.
Because sometimes if they're at home and they've got their computer, they can pull up, especially if you're on computerized charting or
as most of you are,
electronic medical record.
Yeah,
that's one of the joys about electronic medical record. They can pull up the patient's chart from home, and they can look in things. And it's anyway. So I say, they're in 305 or whatever, and just say, she had a hernia repair, and she's feeling nauseous, and I've given her Zofran, and there's, she's it's not working. What are some other things that we can try? So you need to kind of know that patient, or know the patient's name, where they are, what they're here for, and what's going on with them. And sometimes you have to give a little bit of medical history. It's important too to know, like, right off bat what they're allergic to.
Oh, yes.
Because if you're calling because you need some kind of medicine, you need to know what their allergies are, because the doctor on call may not know that.
Yeah, and I've had this happen.
And then you have to call them back if they need something.
I've had to do that because they've said, hey, I gave him an order for Zofran or an order for some pain medication or whatever. And I'm like, okay, bye. And I go in and I put in the order and they're allergic to it. I'm like, or not allergic to it, but allergic to a component in that medication that I wasn't aware was an issue. So and that kind of brings into a point I wanted to make.
And you'll get grumpy doctors who don't want to be called back.
Oh, yes, especially for something like that. But it's important when you're talking to these physicians that you, especially if it's on nights, that you are able to be in front of a computer because they may say, oh, wait, what's their potassium?
Oh, yeah. What's their creatinine level?
What's their creatinine? That's a frequent one when you're asking about medications. A lot of, meds are excreted in the kidneys or harder on the kidneys, and they want to know maybe what their creatinine is, or they want to know their latest blood pressure, or, are they positive or negative with their ins and outs. And, they may have questions that you won't anticipate, but you want to be able to get to the answer very quickly. So when I was a brand new nurse, I always, whenever I had to page a physician, made sure that I was paging them and was available to be at a computer or already at a computer. So when they called back, I could answer their questions pretty quickly until I got really used to that whole flow of things and then understood and could anticipate some of the questions they'd ask.
And, this isn't necessarily, just for like when you're talking to an on-call team. Sometimes a doctor is seeing so many patients during the day and they've already been in to see that patient. And sometimes they need a little reminder of what's going on. So that SBAR method and being by a computer is super important. And I always like to, when I'm precepting, I always like to, do a little rehearsal before my orientee is calling the doctor for something and just say, hey, and I pretend to be the doctor and I'll start throwing these outlandish questions out to just be mean and give them a hard time. But my orientee, but
well, my preceptor at my first job did that because I had graduated nursing school and never paged a physician. And I had to page a cardiovascular surgeon at 3 a.m. about a policy thing that says, hey, if this lab comes back, you have to notify the physician. And I knew we all knew they weren't going to do anything, but I had to call and let them know, and I had to document that I called. And I was really scared about it. And I sure did get a grumpy physician. But it's important. I think it's very helpful with your preceptor, especially if you're really nervous about it, to ask them to kind of go through it. Do a little
dry run.
Run, and then, yeah. And also, I know this is something that took a little learning curve. I had never paged people before, so I didn't know what I had to do, like practically. Like, okay, I have to put in the 10-digit number. And then it's going to beep 3 times or 4 times. And then I have to type in my callback number. And when you're brand new, you're like, what the hell's my callback number?
Yeah.
Or the worst is when you put in their number correctly. So it's going to page them. And then you put your callback number in wrong. I did that. I got made some physician real mad because I had paged him 3 times because the first time I screwed it up. The second time I screwed it up. Yeah.
Sometimes, depending on where you work, there's some text paging, which is now available.
Which is wonderful.
It is nice. In some aspects, some aspects it's not. But, that's also something where you text the problem, so it's also got to be kept within a certain number of letters or whatever characters.
Yeah. It's like Twitter.
So you also have to keep it short and brief. So that's something that takes practice. But just, if you need to write it all down before you say it, do it.
Yeah, do whatever's going to get you to feel confident and comfortable with that, because it is a scary situation, because honestly, they expect you to know a lot. And all of a sudden, you're responsible for these patients that before it was all very theoretical. And now it's like, no, you got to do this now. So it's pretty scary. So encourage you guys to practice and get support from your preceptors. And honestly, I think one of the big important things and aspects of this is when physicians are rounding, taking initiative and introducing yourself to them and kind of breaking down that scary barrier and like, hey, we're both just people taking care of people. Like, hi, my name's Katie. I'm a new nurse on the unit. It's really nice to meet you. Yeah. And taking the initiative to do that. So you put a face with people and start to become known to people so that when you have to call and stuff, it's like, okay, you know this, you've met this person before.
Yeah, don't be intimidated. I've learned that it's really good to introduce yourself. And, I know at my travel assignment, I, as a traveler, you're a brand new face and you're only there for a few months. So I just made sure I was like, hey, my name is Elizabeth and I'm a traveler here. I just started last week, They really appreciate that, I think.
Yeah, I think people appreciate breaking down that first little
That
barrier.
intimidation.
I
Yes.
guess. Yeah, because there are a lot of physicians out there that don't mean to be intimidating, and
No.
they really like it when
No.
people introduce themselves. But they meet a lot of people too, so they may not know if you're new or whatever. So the quicker you can kind of build rapport, the better. Same thing with nurse practitioners. Oh, and so actually there is something I wanted to mention earlier before we went into the whole round or all of calling and stuff. So, going back to our Dr. Smith and his colleagues, a lot of physicians now work with PAs or physician assistants or nurse practitioners. They kind of help do some orders and help them out get through their day, or they can some of them work independently. I know nurse practitioners can, but a lot of times when you're in the hospital, you'll see you have a physician who then has a support staff, and a lot of times, especially during business hours, you can call that PA or NP and get some of your basic questions answered. Or if you're at a teaching hospital, you'll call the resident first. And so you can interact with them and get their information. And then if needed, get orders from them. And sometimes you'll call them and they'll say, you know what, I don't actually know how Dr. Smith will want that. Can you call him directly? And then they'll, okay. So I typically, if possible, try the PAs and the NPs first, if they have them.
Yeah.
And I remember that was a really tough thing at the beginning when it was like, I'm trying to figure out who these doctors are, who their what service line they're with, and also who their support staff is.
Yeah.
And I just want to know who to call when I have a need. And that was a really hard thing for me to figure out. So the sooner you can kind of figure that out, the better for each physician. Yeah, Dr. Smith is seeing them, but I didn't know Dr. Smith had 2 PAs that I had to call first before calling him. Don't get mad at me for not knowing that.
Right.
So trying to figure out that lay of the land is really important. In addition to the whole on-call thing. So I encourage you guys too, if you have what I liked to do when I knew no physicians working around, but sometimes I'd be working with surgeons, so they would come see the patients after they did surgery, especially on the floor. So they'd see the ICU patients in the morning before surgery. They'd do all their surgeries, and then they'd come see round on the floor patients after their surgeries. So sometimes it'd be 3, 4, 5 o'clock before they'd come around with their normal rounding. Which is fine, but if you know that technically the on-call person starts at 5 o'clock, I don't want to wait around for you to potentially round at 5 for a routine thing, because a lot of times every day you'll have a question or two for the physician that is kind of routine and not an emergency. It's not something that's going to justify me calling and interrupting you in surgery. I'm just going to ask you when you come by. But it's really important to maybe if they haven't rounded by close to 5 p.m. to give them a call, because a lot of them will turn their pagers off at 5 o'clock. So that's why it's important to know at your hospital what the call times are. So if it's most places, it's 8 to 5.
Yeah. And one thing that I've experienced myself, and I've had a hard time learning this, is know your phone numbers or know where your phone numbers are.
Yes. Oh my gosh.
Because there's lists and lists and lists.
So many phone
and I
numbers.
actually now, I made copies of my phone numbers, and I will carry a clipboard at work, and I've got those numbers handy.
Yeah, and you're never gonna get. I think I only memorized the intensivists. I only memorized that number, but the rest of them I always had to look up.
Because if you ever are in somewhat of an emergency or it's an urgent issue, and you're going around looking at phone lists, I never can find the number. And
of
the
course
number's
not.
right there, but I can't find it.
It is right in front of my eyes.
And you will learn the common numbers as you go along. But in your orientation, especially, make sure that you guys go through the phone where your phone lists are and know your phone numbers.
And how to use the phone and how to put people on hold and how to transfer them and how to page people.
How to transfer, yes. Okay, so let's go into a little bit of team rounding. This is something that if you're working night shift, you may not experience as much as day shift, and this also may be something you may see more of in critical care versus being on the floor. But team rounding is awesome. Everybody should do it. Every patient should have it. And I don't care where you work, but what it usually consists of is that attending physician. And if there's residents, students, whatever, that are with the attending. So you have the attending, the physician, or the resident, if applicable. You may have a pharmacist there. You may have someone representing rehab services. But what you do is they go around patient to patient on the unit or the patients that they have. And you as a nurse also need to be present. But going around and discussing, okay, why the patient came in, what's going on, and they discuss pertinent issues that may have happened the previous day or the previous shift. They go through the lab work, the medications that they may be on, and they discuss kind of the plan for that day with the team. It is so essential because I feel like you get a good grasp on, okay, you know what, this is what I need to, this is what we're going to do today.
Mm-hmm. You get a good clinical picture, which is hard to do when you just walk in. And,
right, it is. And so, it's important as the nurse to be there. Yes, it usually happens at, 7:30, 8 o'clock in the morning when you're just getting around to seeing your patients and assessing them and passing their meds and everything. But it's so important to do. If you have questions that have those routine questions that weren't called overnight or whatever, that's the time to ask those questions.
Mm-hmm.
And usually sometimes those questions are even answered before you have to ask. It's your time to learn.
And one other thing, too, we called it team rounding, but some hospitals may call it interdisciplinary rounding. I did want to throw that in there real quick.
Interdisciplinary rounds, because you may have multiple disciplines present. But it's a time also, too, for you to kind of write down, like I said, write down what your questions are. And maybe you can get kind of all the things that you need in that day.
Mm-hmm.
So you need to be there and you need to listen. And I know I have gained so much knowledge and information from just listening to the attendings talk. And especially if there's residents there, they teach. And they, one morning I was listening to one of the attendings kind of break down. I had a patient on a ventilator, and they broke down the process of a breathing trial. This is something that you do to evaluate or assess to see if the patient is ready to be extubated. And he literally broke down every aspect of that breathing trial and what that means and what that stands for and what we want to see. And I didn't know all of that. And it was pretty awesome. So I was greatly appreciative of just being there, being able to listen. So it's an excellent time to learn. And I know that if you are working in a hospital in a critical care area and you're in a nursing internship, we actually have some of the nurses on some of their days just do nothing but go with they go see all the patients during interdisciplinary rounds. And it's just a way to learn. Now, you may not have that interdisciplinary round in where you work, but if your attending doctor is going to see your patient and you are present and you can be in there, you need to go in and evaluate when they make rounds. I've seen it where nurses don't go in there. It's especially on the floor. It's really hard, especially if you have patients kind of scattered all around on different halls and stuff like that. You may miss them. But I will honestly, if I see one of my doctors going into another room, I'll stop what I'm doing and go in there.
I will do that too. It's really important because I don't know about you, Elizabeth. When I get report, I write down questions for the physician.
Right.
And a lot of them, most of the time, are not questions that necessitate an immediate call. So when they're rounding, I want to ask them those questions, and I don't want to have to take the time to page them and wait for a response. So it's really important to utilize that time appropriately and be, because you want the best time to talk to a physician is when they're standing at the side of your patient's bed looking at them, not when you're interrupting them with their, not, you need to call them when you need to call them, but when they're rounding other patients. Like, it makes so much more sense to be there. And then also you're able to hear exactly what they tell the doctor, because I've had patients say, no, the doctor said this, when they really didn't not.
No.
And or maybe the doctor said I could have this, or the doctor can give you orders or let you know what to expect, or hey, I'm going to discharge this patient later this afternoon. I didn't let them know, and I don't want to chart yet. I won't have time to chart, but just so you know. So those kinds of things. I can't stress to you enough how important that is. And then it also gives you more rapport with the physicians, and then calling them isn't so terrifying if you're consistently running around them. There is something though I did want to define, because we said it, but we didn't really define it for people that might not know, is resident, the term resident.
Yeah.
So residents are in teaching hospitals, and they are a medical doctor who has completed their undergraduate degree and then their medical school, and now they have been matched into a residency program.
And they're doctors. They've passed their boards.
Yes, they are.
So now they're basically working in they're going into what they're looking to see what their specialty is, or
and they're new doctors, and it's really important to be respectful of that. I know people, they're giving orders and stuff, but it's their first experience, like being in charge like that.
They're fresh MDs.
Fresh MDs. Oh my gosh, copyright that. Fresh MDs. So it's important.
Fresh meat.
Yes. And I've seen some nurses be really not cool to MDs or to some residents before.
Yeah.
But sometimes, a fresh nurse and a fresh MD are really learning a lot at the same time together.
Right.
And so if you can complement each other and support each other, and, maybe they don't know the typical procedure for when a patient has had their Foley catheter removed 10 hours ago and still hasn't voided. Maybe they don't know to order a bladder scan and then to order a straight cath. Like, maybe they don't know that stuff, and like, instead of acting like they're crazy for not knowing, but really kind of supporting them. So that's another person on the team that I wanted to make sure that you had the definition of.
Yeah, and you'll hear you'll hear intern, and I believe the first year residents, so they just passed their boards, they're done with medical school, this is their first year of residency, they are referred to as interns. So typically you'll have an intern, and then you'll have a second year, third year, fourth, and then a chief resident. And the chief is like literally this is their last year, and they may actually be over, the chief resident is usually over like a group of residents who are less experienced. I know in the trauma unit that I worked in, I didn't always see the chief at night. We would see in the critical care unit, we'd see the second and third year, usually the third year resident. They were kind of hanging out with us, and they would always go to the chief if there was something they couldn't quite figure out.
Or if you're asking the resident or telling them something and they're not responsive the way they need to, then you can just go up the chain.
Yeah, you can go up the chain.
Hopefully you don't have to.
Hopefully you don't have to, but there is a chain of command, and then there's always the attending. And let me just say, I actually really enjoy working with residents because I know in a critical care setting, they're there, and it's just so nice sometimes to just have that physician there beside you.
Yes.
Very reassuring, but it's kind of cool because they're open to learning from you, and you're learning from them. But it's really cool to see physicians grow, and you realize that they're learning too. So
it reminds me of that Scrubs episode. I love Scrubs. That show is so funny to me, even though I know a lot of it's not accurate. But one of the beginning episodes, JD is talking about his role as a resident, and Carla, the nurse, and he talks about when you start out as a resident, the nurses do know more than you, but then slowly your training really starts to kick in, and then they develop into that specific physician, because the physician's focus is very different than a nurse's. But truly, when they start out, the nurses really maybe practically policy thinking wise are a little bit more versed in that.
Right.
So that's kind of an important dynamic to really realize.
Yeah.
But let's talk about mistakes. Some maybe new grad mistakes that you've seen, that I've seen working with advanced practitioners. I have a few here listed. One of them, actually a doctor told me this. I didn't personally realize this, but a physician came to me I asked about this specific question. First thing that they said was, I get really frustrated as a physician when I have a PRN medication, an as-needed medication ordered, and it has an indicated use, and the nurse is not using it for that. So for an example, I have a PRN medication of lorazepam for seizures, but the nurses are using it for anxiety.
Yeah.
Or agitation.
Actually, that's practicing.
That's illegal.
That's you're practicing it without a medical license when you're doing that.
Yeah, and that's the thing. I remember this physician saying, if my patient is agitated to a point where they need a anti-anxiety medication, I need to know.
Right.
Don't snow them all night, and I see overnight it looks like they've got 4 doses of Ativan, and it looks like they've been seizing all night.
No,
I was never notified.
Point.
Like, just because you have a PRN medication doesn't mean you can use it no matter what. And that's an important thing that I personally just didn't think to do, but apparently was pretty common from this physician. And I really appreciated that, because I could see, oh, they've got Ativan ordered, I'll just give them Ativan. Well, if you look, it's indicated for seizures. So if you want to give that because the patient is agitated, you must get a new order. Mm-hmm. Almost like if you want, what's another one? Like a pain medication, like you've got to use everything. What I was thinking, an antihypertensive, like you have hydralazine ordered for a systolic greater than, 170. So if the patient's blood pressure is 160, you can't give that hydralazine.
You're not supposed to, right?
You have to get an order, or you have to you talk to the physician and change the indication. So that was the first one that I thought of when I was thinking of this. But
no, I think that's a really good point. I think overall, kind of just being ill prepared when you're talking to a physician.
Oh, big one.
And I think things that physicians appreciate when you're communicating or addressing needs is they like to know number wise. So the other day, for example, my patient needed more pain medicine. So the patient was telling me, their patient's their pain is 8 out of 10. And, I had given morphine, 2 milligrams, and it wasn't working. So things that I've learned to do is give the not quality, but quantity. So I call and I say, hey, I just gave this patient 2 milligrams of morphine. Their pain is still 8 out of 10. It's not touching them. Can we go up higher? They like those numbers. Mm-hmm. Or instead of saying, gosh, my patient's really hurting and da-da-da-da. Well, how bad are they hurting? We got to use that numeric pain scale.
Yeah, we've got to quantify things. Or they're
if your patient's not able to speak, it's, their heart rate is up. They're agitated, restless in the bed. They appear to be in pain.
And I've tried blank, blank, and Annie, maybe even in your mind having an idea, because you may get the question back, well, what do you think we should do?
Right.
And have kind of, you don't have to, but have an idea of, okay, what would be something that I could suggest?
And sometimes I'll even ask my patients. So, a lot of times you'll have a hydrocodone or oxycodone ordered for pain, and they've gotten hydrocodone, and I'm like, okay, it's not working. So I'll say, well, have you ever taken something that kind of helps you? And they'll say, you know what, I took a Percocet once that helps with pain. Sometimes kind of getting not guiding, but learning what works for the patient, because not all pain meds, and I know we keep going back to pain, but you're going to make a lot of phone calls for pain medication.
Yes, you are. Sweet Jesus.
But kind of knowing what works for that patient. But going back to providing the right information, it's good to give specific information, because maybe there's something else going on with that patient that not necessarily you're trying to, you have a suspicion about what's going on, but maybe those doctors need to get that information because maybe something else is really going on.
Right, like that agitation thing. Like maybe we had some increased ICP, and that's why we're really agitated or whatever.
Or they're agitated because they can't breathe. They're really, they're struggling to breathe. So, there's a lot of things. So giving, having, or I don't know, quantifiables, and being prepared to, like we talked about, being prepared to provide the MD with information, not having correct information. I mean, maybe you wrote the wrong labs on your other patient. The patient's hemoglobin is 10, but you're calling, you said, oh, well, the patient had a hemoglobin of 7. That's a big difference. So you need to have the right information.
And that's why having the chart in front of you is really helpful.
And then I think sometimes the docs, they want to see who their nurses are that are taking care of their patients. I think sometimes, I know in a critical care setting, you need to go by, and when your doc's going in to see those patients, you need to go in and see them.
And it's not like, and I feel like people think it's like, okay, I'm a physician, I'm going to do my physician thing, and the nurse is going to do their nurse thing, and then the PT is going to do their PT thing. It's like, no, we're all taking care of this patient together.
Right.
And the more that you can touch base as the nurse leading the healthcare team with everybody else, the better. So I think that is really important. And then one other thing that when I asked that physician about common kind of new mistakes was, one of them was an emergency physician and said, and I think it probably applies to emergency physicians or critical care settings because that's where physicians are 24 hours. But, when I'm putting in a stat or urgent order and they're not doing it quickly, it's like,
oh yeah,
really
stat labs, guys, if you've got stat labs ordered, they need to be done within 15 minutes.
Yeah. And it's not like, hey, we're friends and we're kicking it. Like, no, like if I put in we got to do this now. We have to do this now kind of thing. So having a sense of urgency with urgent stuff was a big thing. Also,
too, when it's ordered stat, the doctor puts it in stat, but yet it doesn't necessarily need to be done stat, and they tell you that's actually a little bit of a pet peeve of mine. So anyway.
So I think that kind of rounds out our episode. Do you have anything else you want to add?
Well, one more thing is calling the wrong doctor about the wrong thing. Ooh. So you, you have an attending, but you have neurology consulted. Well, your patient's having neuro changes. Yes, you can call the attending. You shouldn't, or you've got the neurologist ordered Dilantin for a patient who's seizing. Well, the Dilantin dose is not appropriate. You need to call that neurologist back. Don't call the attending.
Yeah, and you know what? That is not as black and white as you would think it would be.
No, it's not.
There are many situations where most of the time you're going to call the attending, but you want to always typically, a good rule of thumb is whoever ordered it, call that person specifically. But sometimes if it's a new issue that came up, and you're not sure, do I call the neurologist, the cardiologist, or the intensivist? Like, I don't know who I call for this. And then, I remember I had called about something, and then the cardiologist said, no, call the neurologist. And I called the neurologist. Neurologist says, why don't you call the cardiologist? And it's like, actually, no. I called the cardiologist. This is a neuro change, and this is something that you need to know about. And I need to know if you want me to do something about it.
And you are going to find sometimes you're beat around the bush with all these different doctors. And I've had to actually kind of get firm and say, look, I need to know what I need to do.
Me too.
And sometimes that comes, you got to call sometimes it's up to the attending. So, I can't, you got to stand your ground and say, look, nobody's given me an answer.
Yep.
I need to know what to do.
Mm-hmm.
Yeah, sometimes that's using firm language.
Yeah, we're getting a little heated about that because we've been in that situation.
Quite flushed at
we
the
are,
moment.
yes, we are. Flush. But it's frustrating because you want it to be black and white, and it's not as black and white. So if you're calling about an existing order, the best rule of thumb I think is to call whoever's ordered it, and then if it's a new issue, try and think about, okay, which physician does this go best to, who would best answer this question. Many times it's going to be the attending, and the attending will say, hey, can you just let the cardiologist know, or can you let the surgeon know? Okay, yeah, I'll go call him or her or whomever. But that's, it's not always black and white. And sometimes people will kind of physicians will kind of try and pass things off on other physicians. So someone else has to deal with it and someone else has to make a decision, which is really frustrating as the nurse who just needs an answer from somebody. So that's, Okay, I think
And
my
breathe.
hypertensive crisis has resolved.
We love our doctors. And
We do.
love our nurse practitioners, and we love our PAs.
And we love trains.
And with that, we roll out. Thanks for listening.
Thanks for listening. No, just to let you guys know, go ahead and check out freshrn.com/podcast. I've got some good show notes and some tips and tricks, just to kind of help you. Remember, this is a kind of a tough thing to go through. You'll get better at it. You'll get more confident with it, and it's definitely a learning curve. So thank you guys so much for listening, and stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat that'll make you scream. I don't believe in playing it safe. I got the urge to misbehave. I've been known to play with fire. Come on, let's get it started. Like a